I'll try to stick to my 10 minutes. It's very difficult. But my presentation is on what we do in our practice on a day-to-day basis and how we should be observing what we do to learn from what we do. And we initiated this registry in Kuwait. This is in 2023. So it's a very contemporary registry. Started in May of last year. And we started with the aim of enrolling 4,000 ACS patients. And as we got to the 4,000 in 6 months, we decided to move on to 10,000. And alhamdulillah, we had good support from our sponsors, from all sorts of banks and other people. And we've been doing that. And basically, the aim is to look at ACS patients with in-hospital and 30-day outcomes. To date, we have enrolled 6,000, almost 6,200 patients whose discharge diagnosis is ACS, because there's about 8 to 10% of patients who are admitted as ACS, but at discharge, they're not ACS. But about 6,200 with the ACS discharge diagnosis, of whom 30% are STEMIs and about half non-STEMI, and the rest are unstable angina. Really a big thank you to a lot of people who contributed to this, many of whom are in this room, actually. And big thank you to Kuwait Heart Foundation and other sponsors. And over the next few minutes, I'll be addressing the current analysis of the STEMI patients. So we'll stick to the STEMI patients who have had 30-day follow-up, which is about 84% of the entire STEMI population, and will address reperfusion mode, quality of reperfusion, and in-hospital mortality. And the hospitals involved are 8 hospitals. All of them are public. In Kuwait, the majority of practice of this kind of condition is in the government public hospitals. The private have a very small fraction, 5 of whom have cath labs, and 4 of which do routine primary PCI, with the 3 hospitals having on-site cardiac surgery. And one of the 8 hospitals is only a referring center without an ER. And this is a contribution of the 7 hospitals with ER. You can see it varies from one hospital to the other, and it's basically because of the catchment area. What characterizes our 1,600 patients with the STEMI is the relatively young age of 53, mean age, the low use of ambulance. We're still in a small country like Kuwait. Patients tend to be shipped with their family or friends to the ambulance, and these are STEMI patients. And the diabetes of 40% and the high rate of smoking. And this is the presentation of the patients with about 6% in the with KILP class 3 and 4. The mode of reperfusion across Kuwait is about 50% primary PCI and 40% fibrinolysis, with 12% receiving no reperfusion. And this is not uncommon. If you look at all registries, not trials, but registries of ACS, you will find about 8 to 10% of patients, of STEMI patients, who don't receive any form of reperfusion. And this is an example from the recent Euro observational registry, where you see, of course, the primary PCI in Europe is a 70% compared to our 50%. And you have that 9% of patients who receive no reperfusion. And this is the mode of reperfusion between the 7 hospitals, and you can see there's primary PCI mostly in one hospital and fibrinolysis in another, depending on the availability of cath labs, and that's the only determining factor. And the transportation for primary PCI is very little, so everybody tends to stick to what they're doing. They either go on with primary PCI or they go on with the fibrinolysis, unless it's rescue when patients receive lytics and they still don't do well. The next few slides will tell us about the quality of the reperfusion, and this one tells us about the quality of reperfusion with the fibrinolysis patients, those who had symptom onset to ECG of less than 12 hours, which is 84% of the 600 patients. And you can see that 80% of the patients would receive the fibrinolysis within 30 minutes from having their ECG. We don't look at first medical contact, the FMC, which is what guidelines look at, because it is a little difficult. Only 20% use ambulance. And when they come to the hospital, the registration time is really tricky. The ECG time is the sure time that we can rely on. So 80% would receive their lysis within that time. Looking at the primary PCI patients, 70% would receive the door or the ECG to wire crossing time within 60 minutes in those hospitals that perform PCI. So that's considered reasonable. And for the entire PCI and reperfusion, about 70% receive the timely reperfusion, whether it is lysis or ECG to wire time, compared to the Euro observational registry with the timely reperfusion, 70% compared to 54% across Europe. So that's how we sort of have our mark as to whether we're doing good or not. But you compare yourself with other people, and this is registry, not randomized trial, and it differs. The quality of reperfusion differs somehow between different hospitals, anywhere from 90 minutes or 90% receiving within 60 minutes in hospital E, compared to, for example, 56% in hospital G. And this is something we need to address at a local level among ourselves. And of course, whenever you have transfer for those few patients who get transferred because of contraindication to lysis, there will be delayed door or ECG to needle time. The total in-hospital mortality, and that's what matters at the end of the day, in the primary PCI was 3.5% compared to 2.6% with no p-value. And in those with no reperfusion, as expected, the mortality is higher at about 6%. Just 2 days before coming here, I jumped into the swimming pool with my grandchildren, and my glass is shattered. So this is not my usual glass, having some difficulty. But so the mortality is slightly higher in the primary PCI arm, although no significant. And we can see that the primary PCI patients are slightly older. They used more ambulance, and they had more primary PCI. So they're a little different patients. And despite that, the mortality was comparable. And if we look at the in-hospital mortality in Kuwait compared to Europe, for example, it was also comparable, although they're not the same patients. And the in-hospital mortality, according to reperfusion in Kuwait compared to Europe, it's all relatively close, something that reassures us. And in conclusion, ladies and gentlemen, Mr. Chairman, it's crucial that we continue carrying out registries in our region, as simple as they are, to understand what we're doing, to be meaningful. And this is something we stressed out as we carried out our registry. You need to cover an entire country, an entire region. You can't be selective into few hospitals. We were able to enroll 4,000 and extend to 10,000 because of everybody's hard work. And the reason we wanted to go to 10,000 is to be able later on to deal with the small subgroups like women. Women is only about 10-15%. So we can analyze out of 10,000. And young patients, for example, patients with shock. This is unpublished data. yet, because it's ongoing.
Dear doctor,
So,
your time is up.
Yalla, thank you for, just give me, I'm going to the, just give me 1 minute. And
1 minute, please.
and the bigger number gives us the ability down the road to analyze, but that's okay.
Can you show up the slide for 1 minute, please? The slides.
That's okay, there's not much. So, and there are a lot of issues that we can analyze and investigate. We're interested actually in looking at our shock patients within the 10,000, how was shock dealt with, and so on. And this will give us the opportunity to do that. And finally, I want to announce this meeting that we'll be having with Sky in Riyadh in January. It's a collaboration between GHA and Sky. And we're in a meeting here, and I saw a lot of young colleagues who have great presentations, might have good research to publish. They're welcome to submit their manuscripts to Heart Views, Journal of the Gulf Heart Association. Thank you very much.
Thank you very much for this very